Hi. So hello everybody, I'm Jackie Drew and I'm the president of the developing subgroup for oncology, hospice and palliative care and HIV/AIDS within the World Congress. And I want to welcome our speaker today is Reyna Colombo, and I've known Reyna Colombo for many years. I've also had the privilege of talking to her and sharing ideas on oncology rehabilitation. And she and her group and our Chris Wilson, our hospice and palliative care coordinator, is also instrumental in developing an oncology rehabilitation system that's gone wide at the Beaumont Health System in Troy, Michigan, and in the Detroit, Michigan area. So without further ado, I want to again welcome Reyna, and I'm going to turn off my picture so people can pay attention to her presentation. Okay, Reyna, it's all yours.
Well, thank you, Jackie. It is a real privilege to be here this afternoon, and thank you, World Confederation, and especially Ann and Jackie for giving me the opportunity to share some ideas with regard to how to develop and implement an oncology rehab program. I understand that there are some countries around the world that are probably far ahead with regard to the oncology program, so bear with us as I share with you what our experience were here at Beaumont Troy. The objectives for today are really, I'd like to take the time to expand a little bit about the understanding of the World Health Organization and its international classification of functioning and disability and health. I find this definition very helpful as we develop our program. Also, I'd like to share with you a homegrown program, which I call PRISM. We'll talk about what some other organizations have as their missions and goals regarding population management. We are going to use the stop-and-field concept because it was very helpful to us here at Beaumont in developing our program. And of course, finally, at the end, we'll talk about some strategies that will help physical therapists in today's healthcare. So I think a good place to start is always determining what is it that our profession is all about. And I know that the World Confederation for Physical Therapy wants to move physical therapy forward so that the profession is recognized globally for its significant role in improving health and well-being. And also the physical therapy profession is that of transforming society by optimizing movement to improve the human experience. The profession, both at the world level and at our own state, is really seeking for us to impact and transform the individuals, the community, and the population. Just a few facts about cancer around the world. It was interesting that to me that 1/3 of the cancer deaths are due to 5 leading behavioral and dietary risks, and they are high blood mass index, low fruit and vegetable intake, lack of physical activity, tobacco use, and alcohol. Tobacco, of course, rises to the surface because it is a very important risk factor for cancer death around the world, and also for just lung cancer, comprising 70% of global deaths. Also, looking at the data with regard to viral infection costs in cancer, we find out that in countries with low and middle income, the death population is about 20%. 60% of the world's total new annual cases of cancers are coming from Africa, Asia, Central and South America, and about 70% of the world cancer deaths are associated in these countries. Then when we look at the rise of cancer going from 14 million to 22 million within the next 2 decades, we can see the importance of our profession as the number of survivors rise. Looking at the, let's see, sorry here for a minute. I'd like to move to this slide. I think it was in the presentation a little bit out of order, but one of the things that we are looking today around the world, especially here in the United States, is how can we add value to the care that we provide. And this whole concept of value-based delivery is now in every head title of health magazines and facilities and institutions. So what it is really is for us to increase the accountability, we need to find a way in which we can provide better care, better outcomes, and do it with less financial resources. Likewise, I believe around the world we are facing increased patient volumes, faster innovation, and demands for higher efficiency. Today, our profession is called to make a contribution to the health of populations in a much more urgent manner to help us understand how we can add value and decrease and create a sustainable oncology program. I would like then to begin to use those concepts that I mentioned to you in the beginning, the World Health Organization concept and the PRISM. So here is this model, which I fell in love with it, and I use it, have used it a lot as we have justified the value of physical therapy. So the World Health Organization and International Classification of Function and Disability and Health, known as the ICF, offers therapists a solid justification to integrate physical therapy in the treatment plan of cancer survivors. This classification describes the functioning and disability existing along the continuum of health. This is especially important as we care for our cancer survivors. So when we're dealing with chronic diseases such as cancer, this diagram helps therapists to give us the interaction, to explain the interactions between the biological and the psychosocial components of a disease such as cancer. The model describes the survivors then moving in and out through impairments of body structures, ability or disability to participate in activities of their choices. In addition, survivors are also affected by internal or external factors that affect their recovery. The classification also helps us define that our survivors need to be assessed in two ways. In the activity capacity, which is what can be done within the control environment, and also with the actual performances. What are they actually doing within their current environment? Looking at the contextual factors that were listed in the diagram, we know that we have the internal and the external factors, and we find that some of them can be barriers or they can facilitate recovery. I would like to propose to all of you that the presence of a physical therapist in the plan of care of the survivors facilitate recovery. Now, understanding that function and disability are dynamic elements and they occur across the continuum of care, and that physical therapists and external factors can facilitate recovery, we can come now to the table much more empowered, knowing that our expertise in the treatment of impairments and disabilities, which is at the very core of our profession, helps integrate people to society. The international classification then supports and validates the value of physical therapists around the world. I would like now to move to this more simple model that was homegrown here at Beaumont when we began to develop our oncology program. It brings three key elements that are necessary to develop a comprehensive program, which are prevention, intervention, and sustainable wellness. With this model, we wanted to stretch the boundaries and accountability of our therapists. We wanted them to incorporate prevention and wellness beyond the traditional physical therapy phase, resulting in a much more comprehensive program. As we develop our PRISM, our vision was to maintain the patients. We wanted the patients to maintain their own health and commitment to healing. And we wanted to do that through individualized exercises and wellness. These models, as I said before, was used at the beginning with oncology, but it can be used for any chronic disease. And our goal was to continue to support our patients through integrated practices and education before, during, and after treatment. So if we begin to look at the first phase of this PRISM, which is prevention, we know that within the stages of prevention, which are sometimes classified as primary, secondary, and tertiary, we can see that we have a very important role in cancer recovery. As we prevent disease, patients that are susceptible to diseases, in the secondary area, we're talking about prevention or to prevent prevent the slow progression of functional decline and disability and enhance activities and participation in the chosen life roles. In the tertiary area of prevention, I think this really gets to the core of what we do, is reducing the degree of disability by restoring or preventing the deterioration of skills and independence in individuals and populations with chronic health conditions. And when I read this really resonates with this whole concept of rehabilitation now that is widely used here in the United States in the oncology circle. And what Dr. Silver, who I believe coined this concept of rehabilitation, refers to preparing the patient before the storm, which will be that of the treatment. So how do you begin to affect the care of these patients when they are at the hospital? They already diagnosed with cancer. But we feel that we can still do this very effectively, and we can hardwire clinical best practice when these patients come into our oncology floors. And at Beaumont, we've done that by participating in daily huddles and multidisciplinary rounding. So with a team of clinicians, we are at the very early stages of admission in the care of these patients. I have put in there as the last bullet the medical executive protocol, because this is a unique protocol and process that we have in our hospital, where our leader of the oncology floor, the physician, signs the protocol and allows to get in right after the admission without having to chase the doctor for an order. Also, therapists during the acute care admission educate patients on the post-acute opportunities for exercises and opportunities to link into fitness programs once the patient leaves the hospital. Now, in the post-acute care, I think that our major role is to partner with the many clinicians that are providing care to cancer survivors. And one of those that have been key for us have been the nurse navigators, of course, surgeons, oncologists, PCP or primary care physicians, and then, of course, with the institutions that receive some of our patients, such as the skilled nursing facilities, home care, and independent assisted living. We also have surveillance programs that we have to partner with them. Of course, the community, any community program that you have also is very important to know. The second phase of this PRISM is intervention, and I think you're very familiar with this area. And this slide, actually, we developed it as we were in the initial stage of our program. We wanted to point out how the flow of referrals will come through. So you can see that the flow starts with a point of entry into the delivery of care in the diagram under A. B describes the therapist doing a consultation or a screen and then writing an exercise prescription for any of the 4 follow-up care services in column C. And those were traditional therapy, supervised exercise and wellness programs, home exercise, and individualized wellness. While this model describes the flow in our specific hospital, other settings might develop their own point of entry. Private therapists, for example, might want to link specifically to oncology groups, hospital settings, or survivor clinics. Or the therapist might get their patients directly from the Department of Public Health or government agencies. This is another concept that we wanted our therapists to have as we develop our program. It was that as the patients move from the acute to the post-acute care, we wanted our therapists to feel like they were also patient navigators in order for them to integrate the care and communicate the plan of care to the post-acute care team. It was important that the therapists thought of themselves as rehab navigators, making sure that the team was supporting the patient across the journey. Once again, when we're talking about navigation, we have to think in terms of the collaborative relationship that we have to have with some of the care providers, such as care managers, social workers, discharge planners. And the research calls them actually traffic controllers in the management of chronic diseases. But specifically when we're talking about oncology, we know that at least here in the state, nurse navigators are becoming those traffic controllers. And the role of our therapists then is to educate these people as to what is our role, and especially of the value that we bring forward in that of wanting to sustain wellness, stabilize functional activities, and if you happen to work for an institution, the importance of preventing readmission. So this is a diagram that we brought forward and shared with many of our team members, and had to do with this concept of prevention of readmission because it's become a huge issue here for institutions at the United States. In the left side, you see the areas in gray, which are some causes for readmission for the hospital. On the right side, you see lack of social support, falls, worsening of function, and unable to care for self. These are the areas where we feel physical therapists can impact upon discharging and can prevent patients from readmitting in the hospital. We now enter the last phase of the prism, which is the sustainable wellness. Physical therapists need to lead in this area of wellness, not only for cancer survivors, but for other chronic diseases. We need to find a way to develop programs that promote wellness during and after cancer treatment. At Beaumont, we developed the Wellness and Exercise Program, which is a fee-for-service using the concept that if cardiac patients are required, for the most part, to attend cardiac rehab phase 3, why wouldn't our oncology patients be required to attend a wellness program, especially after their very extensive and complex treatment? I'd like to share information with regard to this study that was done between Beaumont and Oakland University. So one of our therapists surveyed over 100 patients, and we wanted to do a descriptive survey, wanted to ask our patient what was their perception with regard to therapists acting as health coaches, health advisors. And it was very interesting to us what we found. This was about 4 or 5 years ago. 33 to 50% of the physical therapists in our practice were practicing health promotion by primarily focusing on physical activity and function. So we were neglecting social, psychosocial, nutrition, and weight management issues. And it was interesting, as we spoke earlier, 1/3 of the cancer are related to some of these very simple issues. 40% of patients receive advice on smoking cessation from their therapist. But our patients had a wonderful and a very positive attitude to our physical therapists as health advisors. So we saw this study as a huge opportunity for us to talk more about prevention and sustainable wellness and keep our patients linked to the therapist as they journey through their recovery. So it was also very important for us to inform and expect our therapists to refer or link their patients to any organization in their community that was supporting their patients, such as the American Cancer Association, Integrative Medicine, the American Lung Cancer Association. And I'm sure that everyone in your own local areas have these type of services that can help you cancer survivors. And if you don't, then of course you create your own, such as the one that we did with the Cancer Survivorship Program. So now let's take a pause and send you our most warmest greeting from our beautiful Michigan and recap what we have talked so far. So we used the World Health Organization from ICF and to really give us a conceptual model to develop an oncology program. It is expected that the ICF classification will be introduced into the legislation of many countries around the world. And it serves as a tool for rehab professionals to measure function and disability, an area that is at the core of our profession and research. PRISM was a much more simple model that really was used to heighten the awareness of therapists that they must practice beyond the pure intervention phase, and that we have a responsibility to our patients in the area of prevention and sustainable wellness. So we're moving now to the stop-and-field model. This model is very important because it really gives you, as the leader, the tools to keep you focused and to understand how you can develop a program through the different phases of administrative, education, and communication structure. So as the leader, you need to know about your internal and external factors affecting physical therapy services in your area. You can begin at your institution, go to your local area, to your national agenda, your specific state or country, and then know what are the key players. And this is very important because it gives you the pulse of the people that are setting policymakers with regard to cancer. Around the world, you might also want to know which organizations are supporting you. At the end of this presentation, I have included a few links for your use of organizations, of cancer organizations around the world. When we look at the administrative structure again, listed in here are a few national organizations that are the gold standards for cancer. I also wanted to share with you that many states in the United States, we have cancer consortiums which guide cancer care and provide us with objectives and strategies. Some of the organizations listed in here is the National Cancer Institute. It addresses the importance of exercise for cancer patients. The American Society of Clinical Oncology provides guidelines for clinical management of long-term follow-up. And then the American College of Surgeons, ASCO, ACOS, and the Commission on Cancer actually mandates the institutions that they must have to provide rehabilitation of cancer. And if you dig even closer within the organizations such as the Commission on Cancer, which is the one who accredits hospitals in the state, as cancer centers, we will find that we have few standards that are very important and that you can utilize to justify the oncology program in your institution. E11, for example, tells us that the oncology program needs policies or procedures to access rehab services. That 1.2 addresses the fact that you must have a representative from rehabilitation at the cancer committee, and this representative does not necessarily need to be a physician. 3.3 addresses the fact that the survivorship care plan, at the end of the treatment, the patients need to have a summary of the treatment and a comprehensive care plan for follow-up. In our organization, we have been able to get into the template of this plan of care. So I wanted to share this diagram, and I don't know if you're able to see it clearly. It has many, many bubbles, and this diagram has been revised 26 times. The reason I wanted to share it with you is because you can see the the patient, first of all, at the center of all we do, and then you have larger bubbles that are around these patients. When we began our oncology program, there were not this many bubbles, but the purple bubbles, which are on the left-hand side toward the top, were on the template. And it has gone through 26 revisions, and we're still on the template. And I think this is hugely important because as the program grows and modifies, we begin to also improve our own services. And then we also begin to see the importance to link between the other services that are supporting the cancer survivors. For example, the long-term follow-up it has many supportive services around it. The most recent one is this cancer survivor clinic on the left-hand side on top. And as you know, the Commission on Cancer has made this a requirement in the states on this year. So we already have to provide the patients with a summary and a care plan. And we are, along with nursing, having conversations at the end of this planned care when the patients return for their visit. Once again, as an administrator, you're the leader. You have to be the voice to speak of the value of physical therapy and not to be simplistic about the fact that we are all about impairments and we are preventing disabilities. And our goal is to, of course, increase participation and integration of our patients to their society, to their jobs, to their homes, their communities, etc. You can see now why these simple statements are necessary to be moved upwards into the higher level of administrations and downwards into your own levels of staff. The next, what we call second leg of the stool of the Stubblefield model is education. And here we need to look inward and evaluate our own strengths and gaps in knowledge regarding cancer care. Is our staff actually able to treat these patients? Do they have the knowledge that it takes? Important because with great power comes great responsibility, as some of my own staff tells me. Physical therapists treating patients with chronic diseases have the responsibility to increase the skill to effectively manage complex cases. And we know that oncology patients are very complex patients. So we have provide our therapists the opportunity to participate in multidisciplinary rounds to multidisciplinary clinics, which occur shortly after diagnosis. Actually, our therapists go in and do screening during these clinics. They also attend tumor boards. We have participated in journal clubs, of course, symposiums. We have brought education to them. We have sent them out to get educated. We have increased the number of lymphedema therapists in our facility from about 6 to 22 therapists. So in other words, you have to promote education, and you have to do a gap analysis to make sure that you address those areas that need improvement. We come to the third leg of the stool, which is communication. How do we communicate our interest in developing an oncology program? The message has to definitely go to the physicians with evidence-based information. When I started doing this, I felt like, well, you know, nobody's going to care, and the doctors are too busy. I shouldn't be sending them any more paperwork. But I was actually quite surprised that many of them responded back and thanked me for the many articles that I was sending them that promoted the services of physical therapy for our patients. You have to share the vision of PRISM, and you have to keep talking about the importance of physical therapy in facilitating recovery. You have to invite yourself at meetings and always volunteer to present or co-present at the community, the hospital, any area where you can bring the voice of physical therapy. In your hospital, you also have to lead the oncology program, and so don't wait to be invited. Invite yourself so you can be at many of these important meetings and where decisions are made, and you can then, of course, create clinical guidelines and flows to explain your role. And most important, obviously, is you have to keep data. You have to monitor your performance. You can also, if you have the facilities or the staff that can help you with marketing, of course, tap into the marketing department. If not, you can tap into flyers, put the information on the social media. As I said before, give lectures to anyone who wants to hear about the role of physical therapy in cancer. One of the things that we did quite a bit was this partnership with these physicians and nurse navigators. I truly believe that you have to find that nurse that advocates for the cancer survivors and partner with them. They become wonderful and very key people in the development of your program. So we talked about collecting data, making sure that you have a scorecard that talks about the demographic, the referrals, and of course, financial trends. Because we don't have a lot of time here, I wouldn't be able to go into a lot of detail about this, but I will urge you to look into the Physical Therapy Journal of Policy Administration and Leadership. My article was published this January of 2015, and much of the information that I'm sharing with you today is there in a little bit more detail. So let's take a few minutes and talk about the lessons from the Tide Pods. And while this is something quite different from the topic that we have been talking about, I thought it was important to talk about what Proctor Gamble did a few years ago. So they wanted to make it easier for the elderly, and they also wanted to make it less messy for busy parents. The fact that the containers of Tide, usually to wash clothes, Tide is a soap detergent, and it's used to wash clothes, and it used to be in huge containers, were very, very heavy. So Proctor & Gamble decided, well, let's just make small pods because this is going to make it easier for everyone. Some of the senior leaders at Proctor & Gamble thought that this was going to be a bad idea because, after all, we were already using a lot more Tide than we needed it because there is only a small amount that you need to do your washing. But nonetheless, they went ahead and developed these pods. And what they found out was that their market grew tremendously, and they were the leaders in this area because they provided a unit dose detergent. And so they were innovators. And like Proctor and Gamble, we too have to be innovators, affecting the cancer survivor's journey with just the right type of therapy as they journey through their recovery. So let's talk about some strategies for physical therapy. We do have the responsibility to find a way to add value in the cancer survivor journey. We need to be aware that in a cost-conscious environment, we are expected to improve quality and improve outcomes. So how do we do this? One of the best ways that helped us here at Beaumont was to standardize the care of our cancer providers. And we started right in the acute care area with just specific processes and specific evaluation tools and documentation tools. So all the therapists that were on the oncology floor follow the same standards. We've done that also in the ambulatory side and during the screening process. We started in one hospital and exported the process to 2 other hospitals with the same tools. This was very, very helpful. We also then forged a strong relationship and partnership with the healthcare team, and we navigated the cancer survivors across different healthcare settings. We made phone calls from our patients, left acute care to the post-acute, and always trying to find the therapist that was comfortable and knowledgeable in treating cancer patients. Knowing that cancer is a chronic disease, we are supporting the survivors in the longitudinal trajectory, from early diagnosis and treatment to the survivorship clinic at completion. Don't ask to be invited to be an important part of this journey. So participate early on at multi-D clinics, tumor boards, and obviously at every stage of the journey, as I said before. When you talk about self-guided care, as we are describing here, we're talking about empowering the patient to be their to lead their care. We're talking about patients making the survivor feel like people versus patient. We have to create, like I said earlier, the longitudinal relationship and have therapists act as coaches and facilitate the patient's recovery. We have to talk to them about prevention. We have to talk about the importance of quitting smoking and nutrition. We have to link them in the community to any type of fitness or wellness program. So in summary, we have used the World Health Organization International Classification of Functioning and Disability and Health as the common denominator to explain the importance of our profession to policymakers and healthcare providers, and even our cancer survivors. We have used a much more simple model called PRISM as a new foundation for physical therapists to incorporate prevention, intervention, and sustainable wellness. We have learned from our local, regional, national areas the policies that are guiding our care. We also are learning from our own organization what are their goals regarding cancer care. We've used the stop-and-field concept as a tool to help you implement an oncology program. We have collected data, and most important, we share this data. I have to say that when I send this scorecard to our physicians, our referring physicians, many of them are calling me back and wanting to know was Mr. So-and-so counted in the data. They are very interested in knowing how many patients they referred, what type of patient they referred, the age, and so forth. And of course, you can do research with this type of information. You can leverage the existing expertise, partner with physicians, involve your staff. You absolutely have to advance the knowledge of your staff. And then, of course, very important, whenever possible, partner with university to advance the oncology research. So this is all I have, and I'll take any questions if you have any. I'm going to advance the reference and show you where some of the references for the Africa Organization for Research and Training in Cancer. And this is Latin American organizations. This is in Asia. And this is Europe.
Reyna, this is Jackie. I just want to thank you for this really excellent presentation. It encompasses so much information on how to structure and grow and be sensitive to the needs of, you know, the patient as well as the institution and the workers. So I just wanted to thank you for this. It was very insightful. It's come a long way.
Thank you, and continue growing, which keeps everybody engaged and very you know, connected and excited about the program.
Yep. There are some questions on the chat line. If you scroll up to the top, Reyna, there'll be a menu that comes down and you can click on chat and you can see some of the questions that are there, because not everybody has a microphone. I do see one from Ann Newstead. She's asking, how long did it take to implement the program?
You know, it took a few years as it is now, as it looks now, but I would say that you start small. We started with having the therapists participate in the multidisciplinary clinic. And from there, of course, the therapist made referrals, as I said before, to either traditional therapy, or we send patients over to the exercise and wellness program. So it will take a good year before you start putting together all your components, but in the meantime, you can start working, and you know, you really have to kind of jump in and do it, and it's not going to be perfect right from the get-go, but if you start to stop and think that it has to, you know, you have to have every flow, every process, you know, every T cross, you'll never get off the line. So it is important that you, as you're developing and improving it, that you are also working with the doctors and you're offering something to them.
There's another question, Reyna, from Ann, where she's asking how responsive were the interprofessional teams, so nurses and physicians initially.
That, you know, I have been a physical therapist for many, many years, and I have to tell you that this was a eye-opening for me. The multidisciplinary team, the physicians and the nurses were absolutely wonderful. They received us. In fact, now they copy me in a lot of their own research, and you know, are also sending information when they're having meetings and conventions and inviting me to their own meetings. So the answer is yes. They are very, very welcoming. And it's just a group of people that are, by nature, I think, very caring and compassionate, and they want the survivor to have the best. And we have a huge role, and they know it. Are there any other questions, Jackie?
I'm not seeing any, but if people want to use their microphones, they can ask a question. While we're waiting for other people to ask questions, oh, here's one. It's from Janet Seidel. Just to add, yes, the team is welcoming, but it is from your persistence that they are welcoming.
Because you have to be that voice, and you do have to be persistent, and you have to be very, you know, you have to be firm. You have to carry that message a lot, every day, and it has to be upwards. It has to go downward, sideways, and every which way you need to do it.
And that's true. There is another question here from Nina Chegbo in Nigeria. How did you get other physical therapists to join you, especially those from other specialties, if any?
Well, I think we were probably somewhat fortunate in our facilities. We have of course, a lot of institutions, let me just rephrase it, begin with having lymphedema therapists, and then they might think that that's, an oncology program, and it might be. That might be the only thing you need if you're just treating a specific type of cancer. But we found that, yes, lymphedema was important, and it was a good foundation for our therapists to have this training and certification. But we also, in our institution, have many different specialties, including pelvic floor therapists, and so the therapists embraced it. And then, Nina, that was a really good question. You as the leader have to kind of try to put your arms around these therapists that have many different specialties, and solicit their help, specifically in the area of oncology. And then you bring them together, you call them oncology therapists. You might be a pelvic floor therapist, but now, because of this relationship that we have developed with our oncologists and specialty physicians and surgeons, your volume might increase because you're going to be seeing oncology patients. And in fact, we saw that. We have pelvic floor therapists treating pelvic floor dysfunctions. But as soon as the therapist started to go to the multi-D clinic and becoming involved in oncology, the volume of urological type of patients and pelvic floor patients increased.
Okay, there's another question from Oren Kajvitz from Hamilton, Ontario. He thanks you for your presentation, for such a good talk. And he's wondering if it would be interesting to see some of your charting forms and outcome measures that you use. Is there a way that they could contact you and
Definitely, and that's what I put in on, I believe, what slide was that, that article that was published in a slide number 36. You can link to the Journal of Policy and Administration and Leadership. I think you will find a lot of information in there regarding the scorecards. And you can definitely contact me, Oren.
Yeah, I can link Oren up with you, Reyna, and I can type your in the chat line. Maybe Chris could type your email.
Yes, I can go. Okay, I'll write it in here.
And then people will know how to contact you. Oren, there's also an article that Deb Doherty is the primary investigator on it, and I contributed to it. And we developed a survey not a survey, but a screening tool for people who are going through radiation treatment. And I can send that out to members if they're interested in it.
Mm-hmm. And I just sent my email to you.
Okay. And I'm going to reproduce it for everybody here, so for all the participants. Nina does thank you for your response. I also was wondering, Reyna, I remember when you were asked to, the physicians wanted to have you, work with them with cancer patients after you had, like Janet said, pestered them and tried to, encourage them to join up with physical therapy for a long time after you were persistent. I should probably use that word. And then they finally invited you in and they said that all the screenings had to be free. Do you want to comment on how well it actually turned out?
Well, thank you for asking. I think that is so important. Yes, when we send our therapists to screens, and we have therapists that go to breast cancer screens, urology screen, head and neck screens, therapists are there for free. We do not charge the patient, of course, because it is part of the cancer center. The multi-D clinics are sponsored by those cancer centers. And so the nurse navigator pretty much is the traffic controller of this clinic. And patients typically come in for the clinic. Prior to the clinic, the physicians get together and they have a tumor board. The therapists are present at the tumor board because they listen to every one of the patient's conditions and the issues that are going on. And then they come out And then the patient is brought up, and then they speak with the nurse navigator. And then the physical therapists are given about 15 to 20 minutes to talk to the patient. And this time is free. We just do a screening, and then from that screening, the therapist then writes an exercise prescription as to what is best for that patient. At the beginning, when we were developing our program, you know, I am the director of the department, and I'm thinking, oh my goodness, we're taking therapists offline. We have a lot of patients wanting to get into our services. How can we justify it? But it was important to do that because, you know, you have to give something to get something back, and you needed really to do this to prove the value of therapy, and it needed to be early on, not at the end of the treatment when patients come back with severe lymphedema on severe impairments. And so we did that, and then simultaneously we were also keeping track of, well, that resulted in some intervention. And yes, for the most part it did. So we have kept track of the financial impact of this program since 2011. And this is what was just a lot of information to share with you, but I have it right here in front of me. And I have to say that the contribution margin, for example, for a patient is in the average of about $200. And remember that I said we also have an exercise and wellness program that is similar to what Cancer Rehab Phase 3 has. Our exercise program, the patients pay a fee of about $9 per visit. And many of them have been coming for a few years, and they are beginning to use that group of that exercise together also as a social support group. Bottom line to what I'm trying to say is the cancer survivors program that we have is not losing money. It's not making a lot of money, but it's not losing money. And yet we are providing a patient with such a valuable service, even though we are pulling therapists out of the clinic several times during the week and not charging the institution or the patients or no one for the care, for the time of the therapist. And just last week, we started to pull another therapist to the to the survivorship clinic. Remember, this is the clinic at the end of the treatment. And we are excited about this because some patients are coming, 6 weeks. Some are coming a year after, 2 years after the treatment was completed. So we're hoping that, most of our survivors would not have any type of impairments or functional limitations, but we're not sure. It's just very early. We think that we're going to be able to help many survivors still. We haven't even touched the area of integrating some of these patients into their jobs, linking them with occupational therapy, which often is very supportive and helpful to bring these patients back into their jobs.
Does anyone have any further questions for Reyna? Looking at the chat room here. Reyna, this was truly amazing. This was such an important presentation. It's giving me a lot of ideas for some of the presentations that we need to address at the next WCPT meeting. People do have Reyna's email. If you have any follow-up questions or you think of something after the presentation, you're welcome to contact her. And as always, you're welcome to contact me. My email is on the WCPT website, or else I can type it in here too. And I want to thank Reyna and let her know that we're going to be awarding her the International Scholar Award from the IPT-HOPE developing subgroup. It's something that we award all of our international speakers who come and talk to our group and try to educate us in ways, you know, related to our topics in HIV/AIDS and oncology and hospice and palliative care. So if there are no, go ahead, Reyna.
No, it's just been a real privilege. Like I said before, I have been practicing and a manager of physical therapy for many years, but I think our role is really changing, and this management of chronic diseases is so very important. It's a public health issue, and we have to be at the table at all levels. And the fact that our own World Health Organization has a definition that is so supportive of what we do, I think we need to really rise to that occasion.
Yep, I agree absolutely. And, you know, the idea that your group has about inviting ourselves to the table and making sure we're out there, you know, years ago I had so many therapists say that, well, we don't get referrals, but it's really up to us to educate people as to what it is we do. One of the things that Deb Doherty and I have done is when we teach our courses in our certificate program, we have our students go out and meet with the case managers or the physicians. And what we're finding is happening is that as soon as these case managers and physicians realize what it is they can do, they get invited to multi-D, you know, clinics and to be on board. So it's really critical that we participate and get the word out about what we can do for these patients. Any other thoughts or comments? Reyna, any last words?
No, just go ahead and do it. It's the most rewarding experience you're going to have, and the interaction with the team is going to be phenomenal. I mean, the people are very receptive to physical therapy, and the physicians especially.
Yep. Okay, well, I want to thank Reyna again, and I want to thank all of you for coming and attending. And I will have this recording up on the website if you have colleagues that missed the presentation. I was so happy to see that there's people from around the world, from the other side of the world, like Robin Box is here from Australia, and Young Home was here from Singapore. Young Home Lin, I'm sorry. He had actually presented a platform at the World Congress on hospice and palliative care. So, and Imad Bashir's here from Egypt. So, really exciting that there's so many people here. And Jerson Jimenez, I'm not sure where you're from. Maybe you could type us in the chat as to what country you're coming from. And then Oren's from Canada, and then most of the other people here are from the U.S. And then Nina's from Nigeria. So welcome all. It's really exciting. Oh, Jerson is from the United States, from Michigan.
Oh, wonderful.
So you're not far away either.
Oh, yes, yes, great.
Thank you and for coming, and welcome.
Well, thank you again, Jackie, and the World Federation. It's been a real privilege.
Thank you so much. And so if there are no further questions, we'll be ending this session, and then our next session will be in August. We're still lining up a speaker, and then in November we'll also have a speaker, and I think one of the people that's going to speak is actually here in this group today, so we'll be sending that out later. So thank you again. Thank you kindly for coming, and I hope that you found this information useful in your clinic. So without further ado, I'm just going to say good afternoon or good evening or good midnight to you, depending on where you're from. So goodbye, everybody.
Goodbye.
Bye, Reyna.
Goodbye. Okay. So who was Jerson? Oh, Jerson was here. Who was this man, Janet Jerson?